In my session, I talked about how do we diagnose high-risk myelodysplastic syndrome. I talked about once we diagnose MDS, how do we determine that the patient is high risk? We talked about different scoring systems that now we have plenty of research telling us how to use the data that we get from a bone marrow biopsy sample, the chromosome analysis, as well as the different molecular mutations that we analyze in these MDS cells. How do we put all that together and determine with these new scoring systems what the risk of MDS is for a patient? And with that information, we also talked about in my session the different newer therapies that are moving forward in the treatment of high-risk MDS. And the most exciting thing that we talked about is we know we have had used treatments called hypomethylating agents. We know we've used them for over a decade now. Some names that you might be familiar with are azacitidine or Vidaza, decitabine or Dacogen. But what we talked about in my session is how do we combine these treatments that we've used in the past and continue to use with newer treatments. And some of the treatments we talked about are oral, so they're drugs that you can take by mouth and that help the cells be killed more efficiently when taken together with these hypomethylating agents. We also talked about a class of drugs that we call immunotherapy, and these are medications, right now they're IV, that you can use to train your own immune system to recognize these cancer cells and hopefully kill them efficiently in combination with hypomethylating agents. So I think from the science perspective, we clearly have a lot of research still left to do to figure out, one, why do people develop MDS? Can we identify it even earlier? And if so, can we treat it even earlier to stop patients from developing full-blown disease, which then we need to do different types of treatment, including chemotherapy and some of the drugs I talked about. The other thing that came out, which I thought was interesting, is figuring out what is the familial predisposition to develop a disease like myelodysplastic syndrome or MDS, because in the past it's been thought about more as, hey, something that you get as you get older, but now we know that there's definitely a familial inheritance component, and we're really understanding that as well. And then last but not the least, as we're exploring these newer therapies, we also want to make sure that they're not toxic to patients. So some of the discussion today was how do we deliver these newer therapies in a way that reduces toxicity and helps improve quality of life and is meaningful to MDS patients as they go through their treatment journey. If you have been diagnosed with high-risk MDS, one of the things that will come up a lot in discussion of your treatment plan is the role of stem cell transplant. And I think being aware that this is one modality by which this disease can potentially be treated and cured is important, because this is something that not just involves the patient, it involves the entire family. It involves looking for a donor that might be within your family. So I think just knowing that that might be something that will be discussed quite frequently, and knowing your options for what does a stem cell transplant mean during your care, when is the best time to do it, what kind of treatment is following a stem cell transplant. I think those are good things to keep in mind if you do have a potential diagnosis of high-risk MDS.